Good afternoon, good morning, and good evening. Welcome from wherever you might be joining in the world today. And thank you for joining this member briefing session on the new investment case for eye health, the value of vision. I'm Jessica Thompson. I'm Deputy CEO here at IAPB, and I'm delighted to be joined by Jack Hennessy, who joins us from New York, where he has been at the UN General Assembly. Jack is the chief economist at the Fred Hollows Foundation, who together with Brad Wong from the Seva Foundation and my colleague Jude Stern led this extraordinary piece of work over the last 12 months. Our plan today is to give just a very high-level overview of the report, its findings, and provide really an opportunity for all of you to ask questions, principally of Jack. So it's great that we have him here on this call. Next slide, please.
Great. I'm sorry. Yeah.
Wonderful. Chip, we could go to the next slide after this. I'd really like to start this talk by acknowledging and thanking first the Seva Foundation and the Fred Hollows Foundation, but really the team of dedicated experts, researchers, partners that you see on screen there who authored this report. It was a tall order to get this done in only, I think, was it 12 months, Jack? But their tireless work and meticulous analysis has provided us with the evidence and tools we need to advocate for eye health at a global, regional, and national level. And principally, this report is more than just data and projections. It's a call to action. It's an invitation for all of us to join a collective movement that really understands that vision and eye health is a powerful accelerator for economic and social progress. Next slide, Jessa. So yesterday, heads of state, ministers of government from over 20 countries, 5 UN agencies met during the UN General Assembly in UN headquarters to launch this report. And it was really encouraging to hear many of those leaders incorporating the new evidence and data from this report in their remarks, making the economic case for vision and eye health, and making their commitment to this agenda. And for those of you who did not join online, Prime Minister Gaston Brown formally announced to leaders and the international community present there yesterday that Antigua and Barbuda will host the first global summit on eye health in 2026. So it is very timely that we have this report, which is going to provide us with the evidence and the tools that we need to advocate for tangible commitments at the summit over the next 12 months. Next slide. So I think all of you here know better than anyone the scale of the challenge that we face, the wasted opportunities, the untapped potential, and the human stories behind the 1 billion people without access to the eye care services that they need. And we also all know that this crisis is set to worsen without concerted action. Next slide. This new report shows that if we reached those billion people, if we eliminated avoidable sight loss in low and middle income countries, we would boost the world's economy by $447 billion every year. And that is the critical benefit that we would get from reaching those people. Thank you. Next. In addition to that, every year we would also create 22 million more jobs. We would unlock the equivalent of 13 million more school years for children, nurturing their potential, but also boosting their future earning potential. We would see 320,000 extra years of life lived. We would also reduce the number of injuries from crashes on roads by 1.2 million and the number of cases of depression by 12 million. and we would relieve 304 million people from the burden of caring for loved ones with poor vision or eye health. Next slide. But what makes this report so powerful is that it combines that ambition of reaching the billion people with the practical, cost-effective steps that governments can implement to deliver results straight away. And given that eye health provision in low and middle income countries still lags behind higher income countries, and the majority of people living without access to eye care services live in these countries, the research really focused on the economic and productivity benefits for 112 countries across Africa, Western Pacific, Asia, Eastern Mediterranean, Europe, and the Americas. The research identified 6 targeted interventions which can be implemented in the next 5 years that would deliver results straight away. And the work that the team undertook was the largest ever costing exercise in eye care in low-income countries. They developed a purpose-built costing tool to collect data from refractive error and cataract service providers. And the costing tool collected data on costs of equipment, medicines, consumables, workforce, transportation, accommodation, and overheads, as well as the service volumes associated with the delivery of those interventions. So it's a really extensive exercise that was undertaken. Next slide. This bottom-up approach demonstrated that a really modest investment of $7.1 billion in those 6 priority interventions could unlock a $111 billion boost in productivity in those countries over 5 years. And through this model, we would be able to reach 255 million people experiencing sight loss in low and middle-income countries. That means that for every dollar invested in eye health, we can yield a $28 return in low and middle income countries, placing eye health and vision alongside other major health and development issues as one of the most powerful opportunities for investment for low and middle income countries. Next slide. I'd now like to hand over to Jack, who's going to talk a little bit more about those 6 accelerators.
Jess, and yeah, it's fantastic to be here. Hi to everyone, and yeah, again, thank you for all the IAPB members and service providers, etc., who contributed to this study. Yeah, I think we had a little bit less than 12 months. I think maybe that's when the idea first came up, but we got it done. I think after Insight Live in Nepal, we really started kicking this off. So it all came together really quickly, and I'm really proud and happy to be a part of the broader team to deliver this. So something that I guess stands apart a little bit from other investment cases or ways investment cases are typically done is they normally use a top-down approach. So for instance, as an example, at Fred Hollows, we wrote one a few years ago that looked at the return on investment of meeting World Health Assembly targets. We took a bit of a different approach to this. And the reason I'm going into a little bit of detail here is I think this is one of the really core advantages of our investment case. So we said, what are some things that governments, service providers, or donors and NGOs could look at to really tangibly decrease the burden of disease when it comes to blindness and visual impairment? And we came up with these 6 what we call sort of accelerator interventions. They're in the report in a lot of detail, so I won't go into each one of these too much, and they're probably things that you're all relatively familiar with. So things like increasing the number of community health workers that are doing screening, so massively increasing the number of people that are actually entering that referral system in the first place. The second one is giving out reading glasses on the spot. So we essentially modeled the costs and benefits associated with community health workers being able to say, yeah, you're a person who requires reading glasses. Here's a pair now, rather than them having to go into a sort of complex referral system. We talked about increasing the capacity in the workforce, so that's for mid-level eye health workers, optometrists, etc. And sort of all of these these accelerators, or certainly these first three interventions, have the same, I guess, approach of bringing the service closer to the person or closer to the patient. So we modeled costs associated with including telerefraction technology, using mobile units, basically decreasing the burden of access for the patient and putting a little bit more on the service providers. The fourth one was boosting surgical productivity. So there's a lot of research out there that shows that there's, small investments that we can make to increase surgical productivity, such as the use of allied health workers and general nurses in the setup of these surgeries, particularly for outreach service camps. The fifth is removing barriers for access. So again, this is all about moving the burden away from the patient to need to go out and seek care, and really supporting them with things like travel costs and counselling, and looking at the benefits we might get from those things. And the final accelerator is improving cataract surgical outcomes, which I'm sure a lot of you on the call are familiar with. And obviously there's a heap of evidence that really has a tangible impact on people's long-term sight post-cataract surgery. Next slide, please. So as I said before, we didn't necessarily seek out to, deep look at what it would cost and what the return on investment would be to reduce the number of people with blindness and visual impairment by 24%. But that's what it came out as. So essentially, if we implemented these interventions from 2026 to 2030 over that 5-year period, the number of people with blindness and visual impairment due to cataract and refractive error would decrease by 24%. When you think about it, that's a huge
Has Jack frozen for everybody or just for me?
Yes,
Just
for all.
checking.
Yes,
gone for me.
yes. Yeah.
Let's readmit him.
Sorry, I think I dropped off there. Am I still on?
You're back on, Jack. Thank you.
Back on, right in the middle of it. Sorry about that, everyone. As I was saying, I think when you think about it, within a 5-year period, decreasing the burden of disease by that 24%, almost a quarter of people in the world, or in the low, middle, and upper middle income countries that we're working in for the investment model, that's a massive effort, and it really sort of sets the scene for future work. It's almost this step change that we need in terms of investment and outcomes to make sure that we eventually get to those sort of 1.1 billion people that are modeled to be living with blindness and visual impairment over the next period, and currently living at the moment as well. Next slide, please. So as Jess mentioned before, there's sort of two ways to look at this report. We've got some high-level figures at the beginning of the report talking about the annual return in the future should we achieve these things. But a large portion of the report and the annual benefits and costs associated with treating that sort of 1 billion people with avoidable blindness and visual impairment. But the majority of the report really focuses on what we can do in this 5-year period. And that's what this slide sort of presents. So it was a really, as Jess said at the start, we were responsible for undertaking a massive costing exercise that I think really truly reflects the costs of service provision on the ground. And the investment is relatively modest over this 5-year period. I know billions of dollars sounds like a lot to a lot of people, but $7 billion over this period, considering it's across 111 countries, is relatively small. And it's predicted to deliver about $200 billion in economic benefits. So that's where that 28-to-1 return on investment figure comes from. Amongst these economic returns, 3.3 million years of schooling gained, so their returns to education. But there's also these social benefits as well. So things like averted deaths from traffic accidents, averted injuries from traffic accidents, averted cases of depression, and poor mental health, and also quality of life gains and I guess all purpose or I vision related life gains as well. The economic benefit by 2030, you can see it broken down there. Employment benefits around 37 billion, productivity 115 billion. The caregiver benefits, so caregivers that are able to return to work, was at about 20 billion, and other benefits associated again with all those socioeconomic outcomes that I've talked about add up to close to 200 billion across those 5 years. Next slide, please. So this map, I guess, just shows where most of the benefits are felt and within what areas they're sort of realised. And you can see that we focused on, I can't say low and middle income countries, which I'm sort of used to, but we focused on low, middle and upper middle income countries. You can see that large portions of the return on investment are in Africa, or in South America and Latin America, and are in South Asia. So the benefits, they're not necessarily related to specific modelling parameters that we really adjusted across these areas. The modelling parameters are relatively consistent, but the benefits reflect the relative burden of disease in these areas. So, for instance, areas where prevalence of mild visual impairment due to presbyopia is high, we might see larger benefits of that returned a little bit later on. So this, again, just really shows that these benefits aren't isolated to one particular area. They really are sort of spread across all the countries that we modelled as part of our report. Next slide, please. I think I'll hand back to Jess for these ones.
Thank you, Jack. And as I said at the beginning, I mean, this report is more than a report, it's a call to action, and very timely that we were able to launch it at UN headquarters amongst government leaders and announce the global summit at the same time, because what we want to be able to do is utilize this new evidence to make some concrete commitments at the summit, particularly from governments, but also from private sector, civil society and beyond, over the next 12 months. And really what we're asking is commitments around three things. We want to act, we want leadership and commitment from the highest levels of government, we want nationally developed plans and strategies to be presented at the summit, and we want policy changes around vision and eye health to be developed over this next 12 months. We want people to allocate, principally resources to eye care and eye health. We want to explore innovative funding mechanisms and foster partnerships with the private sector, and we want to accelerate. And I think, as Jack said, this is where the investment case differs from a lot of other investment cases that exist in the sort of health and development space, in that it provides, a really clear roadmap for countries and 6 interventions which if they invested in now, would provide, a huge return on investment and be able to see results, immediately. In addition to that, we want to harness kind of partnerships and collaboration across the sector, and also fast track research, technology and innovation. So those are the sorts of commitments that we would like to see at the summit next year. Next slide. So just to conclude, before we move on to Q&A, and the sort of main takeaways of this report, please do go away, read the report. There's a very lengthy document. There's also a shorter, I think 10-page document as well, that was very valuable for our meeting so far with governments. But the sort of headline takeaways are principally the return on investment figure, $1 gets you $28 back, which is a really significant sort of evidence that we can now include in our advocacy and communication on eye health and vision. As Jack said, a modest investment, and it is modest, of 7 billion in those 6 targeted accelerators would deliver results straight away, reverse the current trajectory on avoidable vision loss, and reach 255 million people by 2030. And if we solve the whole problem, if we reach the billion people without access to eye care, we would see a return to the global economy of $447 billion. And what I would add to that is that obviously this new report also incorporates, the data and the links between eye health, not just as an economic issue, but also as a social issue, and how it links to education, road safety, mental health. And I think, that's a very important narrative and communication message in the way that we advocate for this issue. So I'd like now to perhaps, Jissa, if you come off screen share, to invite questions from the audience, and just really take this opportunity to have Jack online as one of the principal authors of this report, to ask any questions that you might have of him, and I'll throw it open. Any questions from the audience? Perhaps while you're all thinking of a question, I could start us off. I mean, I guess it'd be helpful, Jack, to understand, how we came to this place, right? Why do you feel that we needed an investment case at all, and what benefit does it bring to all of our efforts in the sector?
Yeah, I think, thanks for the question. I think we've kind of known for...
Recording in progress.
I think we've kind of known for a long time that eye health, particularly refractive error and cataract surgery, among the most cost-effective interventions in the world. Access to cheap cataract surgery was sort of invented or popularized in the mid-90s, if not a little bit earlier. And refractive error, cheap solutions exist, but for some reason, as we all know, eye health just hasn't been...
Recording in progress. Sorry, Jack, I think there was an interruption. Can you still...
Yeah, sorry.
Yeah.
It looks like my computer's... If you can hear me okay, that's all right.
We can hear you.
Yeah, thanks. We know that eye health interventions, again, are among some of the most cost-effective in the world. And for some reason, there's been a lack of prioritization in this area. We see other areas of health, nutrition, other health adjacent or development areas like education, getting large amounts of money, and I fundamentally think that eye health should be in the same conversation as those. So I guess that's kind of why I think we needed this investment case. It was really, really important for us to make sure that it was coming from a sector. So it was fantastic that IAPB could sort of convene the group of experts that it took to lead this and get a real source of truth, so that when we're out there talking to different governments or donors or other NGOs and service providers like ourselves, that we were really speaking from the same message. And I think finally, just one of the reasons that this investment case was required is it massively extended the range of countries for which we have results. So now we've got results for around 111 countries, and I think over the coming weeks, IAPB will be doing a bit of a deep dive and some dissemination work into some results from those individual countries. So we're certainly here to support, advocacy efforts and efforts to really use this investment case for advocacy within national governments. We don't need to just refer to global figures. We can refer to specific in-country disaggregated figures, and I think yeah, that was a real need prior to finishing this project off.
Thanks, Jack. Good answer. I think I have a hand up from Louisa. Hi, Louisa.
Hi, Jess. Hi, Jack. Congratulations, IAPB, Seva, and well done, Jack and the team. You know, what a great report. And finally, you know, some really strong figures to make the case around eye health given budget constraints. We've just seen Germany today slashing their aid budget in half, and it's going to get harder and harder for us to make the case. But having a financial return on investment is so important. Yesterday in the launch, we saw Dr. Monjrul Kabir bring out the importance of this report for gender equality as well as other social health, social, economic and development areas. Can you talk, Jack, a little around where we can take this to use it for those areas like women and girls and the other areas?
Yeah, sure. Thanks, Louisa. I guess reports previously have focused largely on three components when we talk about economic productivity. So things like labour force participation, things like productivity while at work, and things like return on investment for education. This report takes it a little bit further in a way that I think is really specific to women and girls. So we incorporated the productivity or labour force outcomes associated with averted caregiving. So we know that in many of these countries where we modelled and in many of the low-income countries where we work, that the burden of caregiving for a family member who might have avoidable blindness or visual impairment usually falls to women, and this doesn't count as paid work in economic models typically. It doesn't count as unpaid labour in a lot of the modelling that we look at from ILO, etc. So what we did is we incorporated this concept of an averted caregiver burden, and we actually put a dollar value on that. So essentially we modelled what would happen if these individuals who got treatment, what proportion of them within each country might have been receiving care from individuals such as family members who might be women and girls, who could then return to the workforce and generate more economic, I guess, benefit for themselves, for their families, for their communities, and for their countries. So that type of work hasn't been done before on this global scale. There is sort of individual country-specific evidence, albeit somewhat limited. It's an area that I think we need more research in as well. But really at a high level, what it shows is that there is an economic return for these individuals who might otherwise not be necessarily recognised when we look at traditional economic measures. And I think extending the investment case to look at those individuals gives us a really powerful piece of evidence to have in our pocket, both to advocate to government for the importance of prioritising women and girls, but also for the importance of prioritising additional work in this area, getting additional context-specific data in this area, and really, figuring out, just as we're framing eye health as a development issue, and we know that eye health now is a development issue, really investigating into why eye health might disproportionately affect and impact women and girls. So it gives us a lot to move forward with in that space, and I'm certainly looking forward to working together with that.
Thanks, Louisa. Thanks, Jack. We have a question in the chat, which perhaps I will take and then maybe hand over to you, Jack, if I've missed anything. The question is, have there been any formal responses to the report from government? So as we said, we had the benefit of Jack and others in the IAPB team being in New York to launch this formally at UN headquarters for the UN General Assembly yesterday. We had over 20 governments in the room, and it was a completely full room, which was fantastic. And many of those governments incorporated this new evidence and data into their statements. And obviously the report provided, I guess, the basis and the foundation for the need to hold a global summit on eye health next year, which, you know, will move the conversation on, hopefully, with governments from what we should or could do to what we will do, right, into tangible political action. I thought what was actually really encouraging was that already in the room we had 4 or 5 countries making commitments to participate in that summit, to develop their commitments further over the next 12 months, working with the sector. And actually, Louisa, you mentioned Germany, which is obviously in stark contrast to the statement that they made yesterday in the Friends of Vision, which, you know, I thought was quite striking and encouraging, that you see, you know, a government like Germany standing up, talking about actually not only the commitment that they could make to their population, but also talking about themselves in terms of being a developed donor country and how they might support low and middle income countries. So given the political climate, I thought that was actually really encouraging that we see governments talking in that way. Okay, so we now have a whole flurry of questions, which is fantastic. So I'll take them in turn. So which eye health interventions have the highest cost effectiveness according to your model, Jack? And how can this return on investment evidence be used to advocate for stronger inclusion of eye health in national health plans?
Yeah, great. Thanks for the question. I'll just make a quick note on sort of cost effectiveness versus cost benefit before I answer this question. This is very much like a cost benefit study. So we look at the costs and then the broader economic and social benefits. So that's where that 28 to 1 ROI figure comes from. In terms of cost effectiveness, we're more looking at things like, you know, the actual cost per screening or the cost per intervention itself, rather than extending it to those benefit pathways. But I assume probably the question is referring to those, maybe a bit of both, but largely what drives this model and what drives the largest benefit in terms of socioeconomic benefit is provision of ready-made reading glasses and provision of glasses for myopia. And the reason is that these interventions, compared to other interventions, are relatively cheap and they have enormous untreated prevalence in the countries where we modelled this investment case. So those interventions, and as well with myopia, we have relatively early interventions. So when we look to calculate those lifelong benefits to increasing years of schooling by about 0.4 for children who might receive glasses and might not have been able to see the blackboard or the whiteboard previously. Clearly, I haven't been in school for a while. I'm not sure if they're still using blackboards and whiteboards. It's probably all digital these days. But
I think they're all using their phones now, Jack.
Yeah, probably using their phones now. But for those individuals that might have learning issues related to eye health at school, those benefits are realised much earlier in life and translate to sort of compounded benefits throughout the life course, which is why they're higher. That's not to say that you know, the other part of our I guess investment case with cataract surgery, that's not to say that doesn't have enormous impact. In fact, cataract surgery itself usually ranks as one of the top 2, usually the most cost-effective intervention in the world, because in 8 minutes you can get someone to go from bilaterally blind to being able to see again. The benefits in our model just aren't realised to as greater extent as myopia and presbyopia benefits or interventions, because the prevalence is a lot lower and people are getting treated a little bit later in life. So some of them might be out of the workforce, so those economic benefits are diminished slightly there. I think the second question was around how this might be able to be translated into action from governments. I think there's a lot of work to do. You know, we sort of celebrated a bit yesterday, saying it's fantastic to be launching this investment case. All this hard work is paying off, but I really do only see it as the sort of start of a lot of work that we can do. And I think that gets down to what we need in each context, what the government is after, what level of guidance they might need, in terms of, do they want really specific interventions like we've recommended in the report, or do they need support with, building health information management systems, all these other things that we work in that we all know are really, really important. In terms of this investment case specifically, I think it gets us a foot in the door to these conversations with governments. I think it gets us in the same room as these really high-profile interventions like education, like nutrition interventions. I think iHealth should stand with those interventions and be invited to every government planning meeting now, because we have this report. And I think from there, it's really up to focusing on the accelerators that we identified in the report as really cost-effective, quick, almost tangential to the actual delivery of interventions, but little modifications to how we deliver eye care. So, for instance, bringing it closer to the people and to the patients. I think prioritising those and really having bold discussions with governments is how this can be best used for advocacy purposes.
Thanks, Jack. We have a couple of questions in the chat, but perhaps we could go to Fiona first, who's got her hand raised.
Thanks, Jess, and congrats everyone on a really well attended launch and a really great report. I guess this is probably more a question for you, Jess. Sorry, Jack. But I wonder if you could speak a little bit towards how this fits in with the other tools in the run-up to the Global Summit and what's coming next in terms of things that can support people's advocacy both at global and at national level, and how all of it kind of fits together rather than as standalone items.
Thank you, Fiona. Really good question. Well, I think, yesterday really was the starting point for a very busy next 12 months for all of us as advocates, right? We now have an official announcement of the summit from a head of state. Our task, really, our effort now is to reach out to governments to work together to start to craft what their commitment to that summit might look like. We have the evidence, we have the data now from the investment case, and I think that really creates a very kind of powerful communication tool for us. And Jack's already mentioned, which I was going to come on to afterwards in a couple of slides, that this investment case and the data and evidence that we have at the global level will also be available on World Sight Day at country level for those 111 countries. So we will have national cases, which will be extremely important for our advocacy. We also, as Fiona and many of you might know, in earlier this year at the World Health Assembly launched a policy framework that really provides the starting point for a conversation with governments about their potential policy priorities in crafting their government commitment as well. So those two documents, I think really provide a lot of support for all of us in that dialogue with governments over the next 12 months. In the end, we want this to be government-led. We want governments to take responsibility and commit to something which is, rooted in their national priorities and population needs. But I think, the onus is on all of us now to work with governments to craft those commitments and those sets of asks. Jack, I don't know whether you had anything to add. And I should say that, those two documents are very much aligned as well. So, the kind of the case for action very much supports the policy framework that exists. That is the more kind of detailed policy set of asks.
Yeah, I think, I'll just add kind of what I said at the start. I think a fantastic uniqueness to this investment case is having those 6 accelerators that are almost asks within themselves, and the investment required is low. We have pretty clear asks, we have pretty clear way forward. I think combined with these other various documents and country-specific evidence, that it'll all work together in a way building up to the summit. But yeah, again, Jess, you'll probably have more awareness of the planning of that than I do.
We have a couple of questions in the chat around monitoring and evaluation. So, you know, in the context of the UN resolution, and I guess in the context of the summit, if we think longer term as well, how do we actually ensure that governments report on financing and progress on eye health in the same way that they do for other health issues? And a similar question, I think, related to that is, you know, what do we see as the role of data collection in improving kind of efforts on these accelerators as well? So, Jack, perhaps you could take a first stab at those questions, and I might have some thoughts to add on monitoring and evaluation.
Yeah, sure. I see them. I'll try to respond to how I sort of interpreted those. In terms of governments reporting on data related to eye health, like there's the Roche report from a few years ago, essentially finding that that they didn't look at all the countries in the world, and they didn't focus on low and middle income countries, but they focused even on like high income countries. They couldn't find specific line items associated for eye health expenditure, eye health financing. It's really, really hard to do. And I think that is a critical first step or next step to being able to look at how governments allocate funds to eye health. Because it's all well and good to go into a government office, into a Ministry of Health, and advocate for more money to eye health. I'm sure probably all of us on this call have been in that position before. But that line item, or the ability to distinguish how much is actually spent on eye health, is often really, really hard to get. And different countries spend it on it in different ways. Some people spend throw a whole bunch of money just spending on procurement, or some governments only fund workforce, and NGOs pick up the slack for service delivery. It differs in every country, but yeah, just to, I guess, finish answering that question, I think it is incredibly important to be able to actually legitimately say within each country, this is what we spend on eye health, and this is each sort of component of that expenditure. Again, what I've said before, I think this investment case doesn't tell us that answer, but it gets us in the room to be able to say, hey, this is an important issue. We should be able to say this, tell this answer, and we should be able to answer this question, and we should also be able to, if we can answer that question, we'll be able to show you and model the returns that you might get from your current expenditure as well. To answer the sort of second question, I think it was about, looking at monitoring of investments data within countries. This is something I've been saying the whole week. We've had a whole bunch of side meetings at the UN General Assembly, and with different donors, with different with different UN groups, etc. And the whole time, I feel like I've been talking about the need for context-specific evidence about what models of care work in each individual country. So again, this ROI tells us about specific models of care, sort of general aspects to models of care that we know are really successful and are going to be really successful in most contexts. For instance, the use of community health workers to do eye health screenings. That's a really good model, and we know that works at scale. But tracking the investments in these things and tracking where models in specific countries may differ from the models recommended in the, or these accelerators recommended in the investment case, is of critical importance. And I think having that context-specific data, having context-specific cost-effectiveness data, if you can get it, adds so much legitimacy to the models that we're trying to advocate for funding for. So if this investment case gets us in the room and they say, great, the Minister of Health or the Minister of Finance says, great, that's awesome. We love all this work. We love economic return. We really want to build an eye health program. Tell us how you're going to do it and tell us how much it costs. That second question depends on the context, and that's where that evidence that that question mentioned is really, really important. I don't know if you have any other thoughts, Jess.
No, I think that's a really good answer. I mean, I would just add that obviously there are existing reporting requirements for member states in relation to eye health. So we do have the WHO global targets that were agreed at the World Health Assembly, which governments should report on. Next year, in 2 years, the WHO will do a global status report. Increasingly, which has been, really encouraging, we see countries reporting on eye health as part of their voluntary national reviews on the Sustainable Development Goals to the UN. And I think what we want to be thinking about is, how do we create a really robust accountability mechanism for the summit that can effectively monitor and track exactly what we have just discussed? And how do we use that, as a foundation for whatever follows the SDG framework, bearing in mind that eye health wasn't included in the original list of indicators and targets for the SDGs. We would hope that, this body of evidence and the work that we all do as advocates means that omission is not repeated in the post-2030 agenda, and so that we actually do see, greater accountability for eye health, certainly on the kind of global stage. So I think we have an opportunity to create something that is much more robust in the context of the summit, I hope, particularly as governments start to think about their commitments and their pledges, which, might be, as you say, Jack and Fiona, around, the policy asks that we've developed, the accelerators, and, principally and ideally financial commitments, to eye health within their national systems. I have a hand up from Azra, our regional chair. Oh, you're on mute, Azra.
Yeah, can you hear me now?
Yes.
All right. Hello to everyone, and congratulations first. I think this is an amazing work, and I think it complements the other materials we have done for the Global Summit already. And I think it's very timely and amazing to have such high quality materials even more than a year in advance. So I think it gives us a very good starting point into the negotiations. I do, however, have a question, and I suppose you know what it will be, regarding the data gap we face in the high income countries. So Jack, if you find yourself in a health minister's office in a high income country, where we do know that we in many places have problems with access and with equity, but we don't have data to back it up, how do we deal with that then? And that's my question. Thank you.
Yeah, no, thanks. It's a good point. And I think we focused on this particular set of countries because we know that is where the vast majority of avoidable blindness and visual impairment exists, is in these low middle, upper middle income countries. So I think it's over 90% across the world. But that doesn't mean that these high income countries aren't important. And you kind of saw that yesterday from I'm not sure if anyone tuned into the launch at the General Assembly, but a lot of the comments and a lot of the really powerful comments were from high income countries that were making significant strides in eye health and really recognizing the need for school eye health programs and stuff like that. So in terms of data for high income countries or evidence for high income countries, we didn't include that in this model, but we used a framework that could be adopted in high income countries should those models be required. But that doesn't necessarily give us much to do now. And so what I would say, if we're in these ministerial offices within high income countries, many of the accelerators and many of the interventions that we talk about are consistent and would be recommended for both high income countries and for these low income countries that we used in our report. So for instance, focusing on telehealth, focusing on an increase in primary care. This is a focus of a lot of high-income countries want to move away from tertiary healthcare, where everyone goes in when they're really, really sick and they really, really expensive care. They want to take it closer to the patient, both because it's better for patient access, but also because it's cheaper for them to deliver. And that's kind of at the core of this investment case. So I would say that these 6 interventions still hold across high-income countries as well. And I would be presenting this evidence as, look, we did include upper middle income countries like Argentina, other upper middle income countries around the world, which are not dissimilar to how some high income countries operate within their health system. And for the moment, I would be frank and say that's probably all the evidence in high income countries that we have coming from this report in particular, but there would be room to expand it further should that demand arise.
Thank you, Jack. Thank you, Azra. I think we have time probably for one more question in the chat, which is someone from Peak Vision. Is there a particular approach to calculate government eye health spending when the services are being delivered as part of integrated general community health screening and general primary health services?
Yeah, there's a number of approaches that you can do. Governments use top-down or bottom-up sort of ingredients-based costing if they're looking to calculate specific funds expended on areas. So, for instance, where a community health worker might be screening for multiple diseases, some more sophisticated governments would have that segmented into the incremental cost of incorporating eye health, for instance, into this screening program. Unfortunately, that is a bit of a pipe dream in many of the countries that we work in. That level of costing breakdown is often difficult to get, and that's where you kind of need these individual studies to find out these costs. So we used a bottom-up costing approach. We looked at the workforce, the consumables, the equipment, etc., included within a typical eye screening and eye exam. We modelled costs for 15 different interventions based on service delivery location and, for instance, an eye exam delivered in a community screening setting versus the cost for an eye exam at a primary care facility versus the cost for an eye exam at a secondary or tertiary health facility. So the way we did that is the correct sort of scientific way, in my opinion, and we did follow some really stringent scientific methodology on that to be able to cost it bottom up, because, as you so rightly pointed out, disaggregating the costs associated with one community health worker from a top-down perspective, like governments might do sometimes, and certainly like budget holders clearly do when they're looking at investing in health programs, is difficult. So just to sort of summarize my answer there, I think you're right in saying that it's sort of difficult to disaggregate the incremental costs of eye health associated with these services, but that is what we've modelled specifically throughout this investment case.
Thanks, Jack. I think that's probably all we have time for today in terms of the Q&A, but I know that there's been a few more questions in the chat, but perhaps what we might do is take some of those questions away, and actually, if after this session and after reading the report in more detail, you do have questions, please do send them through to our team, and we can put those questions back to Jack, Jude, and the kind of core writing team, now that they have lots of time that they've finished the report. I joke, there's lots of things happening. Jessa, perhaps we could just bring up the final few slides before we close off, most of which actually I think we've covered, and it's really just to say that this investment case is now available on Ocean Atlas. Please do go away and read it, or read the short summary document. As we've mentioned, on World Sight Day, we will also be launching the national cases. So that data for those 111 countries with particular media focus on a set of priority countries will be available on World Sight Day, and I think will be a really vital advocacy tool in those 111 countries. Next slide. And yes, so please do go visit Vision Atlas to download all those materials. I'd like to end with really our call to action to us as the sector, as the international sort of eye health community, and that is that, you know, we have now the announcement of a global summit and the opportunity to really kind of accelerate commitment and action at a country level. You know, we would hope that a number of governments will come next year to the summit and make concrete commitments and pledges to eye health, but the onus, I think, is on all of us as advocates in the sector to make that happen. So please do go away, use the report, use the policy framework and the sets of policy asks that exist there to develop, you know, your set of asks and your messages to the governments that you're working with at a national level, so that we can really come together to make next year a really sort of powerful and meaningful moment to reaching the 1 billion people without access to eye care services. And if you're interested in getting more involved in that advocacy effort, then reach out to us at IAPB. So thank you very much to Jack for joining us from New York, and for all of the work that you've done to produce this really powerful piece of evidence that will help us greatly in all of our efforts. So thank you, and thank you everybody for joining the session today. I hope it was helpful.